Arganissima, New York. Your exotic skin, hair, and beauty source, and your one-stop shop for all your natural and organic skin and hair care, featuring authentic organic Moroccan oil and prickly pear seed oil and much more. Bringing you only the best, straight from the source and proudly produced in the USA. So what are you waiting for? Shop today at www.arganissima.com. Arganissima, New York. Your beauty is our duty. Arganissima, New York.
Welcome back, everyone, to the iHealth channel, the Fit and Fab channel, iHealth Radio with Hurricane H. New day, new show, new topic. And today we will be focusing on a topic I think that affects everyone around us, sometimes even ourselves. And, if you're listening today or watching, you're probably going to relate to this somehow, somewhere. And the topic is nothing else than the chronic pain, which a lot of folks live with, unfortunately, and they might not have to. And today we're going to find out what ways we can do to help people maybe live a better life, healthier life, and easier life with our special guest. And our special guest today is Dr. Mitchell Yass. He's a doctor in physical therapy, but he developed his own method. And we're going to talk about the Yass method today, and which is deep, and we're going to understand it. But before we go into all that, first things first, Doctor, welcome to the show. Thank you for being with us and for accepting the invitation, and certainly for sharing with us your insights today. So first thing, I'd like to ask you to give us a little bit of introduction about yourself, your background, and then we'll take it from there.
Sure. So my path as to where I've come to where I am today actually starts as a child. I was the classic 99-pound weakling, had sand kicked in my face, bad self-esteem issues. And I decided that I was going to learn how to make muscle, how to grow muscle, how to weightlift. And where the average person, I'm not saying in the initial portion, I didn't do this. I go to the Joe Weider magazines, the Muscle Training Illustrateds, and all that stuff. But for some reason, partly because my metabolism is very fast at the time, I wasn't able to put muscle mass on. So eventually, I literally took a high school physics course and started applying physics laws to weightlifting, understanding force vectors, lever arms, all the aspects, potential energy, kinetic energy, all the things that allow you to understand how to push the optimal amount of force against the resistance that you're trying to push against. And over a 4-year period, I put 40 pounds of muscle on. I go from 160 pounds to 200 pounds in 4 years. At the time, my occupation, I was a project manager in construction, and I just found that it wasn't fulfilling to me, so I decided to leave that, and I find out about this thing called physical therapy, and the good news was that you get to work on people's bodies, but it doesn't require the same medical schooling as a physician, so that's what I decided to do. So in the first couple of years, you're just learning a lot of theory, and it's all book aspects, and finally, at the end of it, now you're going to do your affiliations. And now you're going to actually have someone in front of you, and they're going to say, I'm in pain, or I've got this, or whatever, and you're going to have to treat them. Now, we were taught that to understand what's causing someone's pain, they're going to get an MRI, and it's going to find in the back a herniated disc or stenosis or a pinched nerve. Everybody who's been in pain, who's gotten an MRI, have heard these concepts. In the knee, it might be a meniscal tear or arthritis, maybe a rotator cuff tear in the shoulder. And once that's identified, your job is to treat that. Well, for some crazy reason, the very first time I start treating people, it just dawns upon me, and I don't even know what made me think of it, to say, can you just show me where your pain is? Just point to where your pain is. And the most remarkable thing presents itself. Where the person is experiencing their pain is not where it should be if the structural variation identified were to create pain. Well, if where they're having the pain isn't where it should be, then the structural variation can't be said to be the tissue in distress creating the pain they're experiencing. And I'm figuring this out in my final affiliation as I'm about to graduate. And so you kind of have this moral quandary. What the hell am I supposed to do? Do I treat based on what I was educated to treat? Or do I try to go on and try to figure out what it is that's causing this pain that people are experiencing? And I went to school. I went back to school at 30 years old. So I was 32 when I graduated. I had a lot of life experience. And to be very honest, I was passionate. If I was going to take this career on and I was going to work on people's bodies, I knew I wanted to have everything I could to know what to do. So I said, I'm going to try to figure it out. I'm going to try to understand. They're going to point to where their pain is. They're going to tell me what brings on their pain. They're going to tell me about everything relating to it. And then I'm going to try to do some tests. And lo and behold, I figure out that in more than 98% of cases, the tissue eliciting people's pain is muscle. It's muscle. Now, what you want to understand is muscular causes, and I'll go through all the potential types of muscular causes, don't show up on MRIs. Mm-hmm. So imagine, I give you an example. You have pain in your upper sharp region. I press where your pain is, and you say, yes, that's it. Well, that's a muscle. You strained the muscle. Can that show up on a cervical MRI? The answer is no. What will show up? Well, a herniated disc or stenosis or a pinched nerve. The question is, because it shows up, does that mean it's the cause of your pain? Well, I'll go into all the scientific, clinical, and theoretical basis to show you, no, it does not. It simply means that's an independent variable that happens to exist, but it's not causing your pain, therefore it doesn't require treatment. And yet, if you go through the medical system, what do you think they do? They find the structural variation, and that is what gets treated. So that levator scapula strain, that muscle strain, just remains. And as a result, if you continue to use your arm and that muscle continues to strain, it continues to elicit pain, ergo chronic pain. So that is the basis, the history of how I came to this. And now we're 28 years, almost 3 decades into it.
Wow, doctor, that is impressive. I mean, I'm just listening. The passion, first of all, like just you love this stuff. I can hear it. I think everybody, God, yeah. It's projecting big time. I mean, I can't even say anything about that. And you know, your story is also incredible because you started from a point of it's a personal thing. And you did the best you could for yourself, and then that stuck with you, and you went a fulfilling career. Hopefully it was, but it wasn't. And then you decided to go to something that you can help people with.
Yep.
Throughout that process, you determined that maybe there's something wrong in this process, because one thing is what we learn. And by the way, that's true for a lot of things. We learn a lot of things and they don't usually apply in real life. There's more to it.
Sure.
But, I mean, there's credit to MRIs, there's credit to what it does and shows some problems that could be, you know, again, hernia disc can happen, and that's a different, but you're right. Is that what's causing the, you can do a chiropractic, you can do some physical therapy, you can align these things, but eventually that's not necessarily, to your point, that pain, you know, management piece, because that there's more to this. Now you discover that it's a little more, and we're going to talk about those. So basically, ultimately, the chronic pain here is a pain that is constant, that is not going away, and you're living with that every day. You wake up, it's there. You go to work, it's there. You sleep, it's there. And you take pills to numb it, but it's not good for you. Your liver now is exposed, right? So today, I'd love for you to break down, first of all, the different types, you know, of chronic pains that the body can have. If there are multiples, I mean, as a concept is one concept, but I mean, there's different ways you can feel, different places you can feel it. And also, like, you know, the science behind it. And, you know, maybe the other thing I want to ask, and we'll get to it later, is the how you are perceived, because you are almost challenging the dynamic, because your views are a little bit different from other maybe physical therapists. And some people may swear with the MRI, that's exactly, and you have your own unique way. It's all good. At the end of the day, you have a method, you've done it for over 20 years and it's working. It's been going on, it's happening, and you've solved the problem for a lot of people. And at the end of the day, again, you and I, we had a quick discussion about different ways that people seek pain management. I've seen people like opioid, and then people get, now it's the CBD treatments and all the stuff.
Right.
There's yoga, there's all kind of these hypnosis. There's so many things. As a matter of fact, I have a show next week and we're going to talk about pain management through hypnosis and other ways. And I've seen actually, some sessions of some of these things, in front of my eyes. And not only that, I do work with seniors, in insurance world, and in a lot of events, they do pain management sessions. They do like education about them and the different angles. But really, it's amazing what's available to us. Today, you are a resource. And, maybe some people know about you. Maybe people not know about you. Today, we want to make sure that they know about you and your services. And now, first question, just as a base, are you located, where are you located exactly?
In Jacksonville, Florida, in the United States.
Oh yeah, good weather.
Oh yeah.
Nice, very nice. You get both. You cross over, you're in Georgia, you're down, you're nice.
Exactly.
Well, so that's good. And you do this local, and you can help people all over, I'm assuming. And usually I ask this at the end, but since we're talking about it, I just wanted to just get out of the system.
Yeah, the vast majority of what I do is actually through Zoom session. So I've written 3 books. 2 books are published by Hay House, the second largest publisher in the world. The books are published here, Canada, England, Australia, India, and South Africa. So once my first book from Hay House came out, which was in 2015, I started getting contacted from people from around the world. And as a result of that, I knew people weren't going to want to fly to Jacksonville, Florida. So before there was Zoom, there was Skype, and it was really at its inception, I was doing teleconferencing sessions 5 to 6 years ago. And so I've been doing that for a very long time. And as far as I'm concerned, I feel like I perfected it. And people have to understand that the diagnosis can be achieved virtually because, as I'll explain, if you have a muscular cause, muscles are also responsible for posture. They're also responsible for movement patterns. So if you have a specific muscle creating pain, I'm also going to find a correlating altered posture and movement pattern. And through that understanding, it allows me to understand that it's muscle and which muscles. And then I just show you how to strengthen the appropriate muscle. So this has been going on for years. This is not new to me. I've been doing it for 5-6 years at least.
Awesome. And you were ahead of the curve because Zoom only took off, more. I've used Zoom before and Skype before, but really the era of Zoom, Asher, with COVID and the pandemic primarily, right?
Yeah, absolutely.
And even telehealth was always there, but a lot of people didn't use telehealth.
Well, hesitant, right? Yeah.
Now
exactly.
It is more, popular, common. I think it changed the way medicine and treatment can be done. So
absolutely.
Awesome. Well, listen, you were earlier, on the whole concept, and you were ahead of the game then, and you're still ahead of the game, and that's great. And and that's really what we want the audiences to hear, to get that feeling that your stuff, and you can help people, and you've helped people around the world. So, and by the way, our show is broadcasted all over the world, so people
that's great.
They download this all over the world. They can watch it anywhere. So technically we have audiences in the world. That's great. I love it. So it's, and the reason I asked this question is because if you're only confined to one location, we're limited to who is going to be available, to the services and to you, but now we good.
Oh yeah, absolutely. I've gone as far as Taiwan. I treated a guy in Taiwan a couple of months ago. So this goes pretty far.
well, so doctor, here's the thing, and we're gonna break down the pain management. So pain management, there is no age. I don't think there is a chronic pain in general. It's everybody. You can
correct.
Be a kid,
that's right.
You can be older. Obviously, it gets worse with age and other type of problems, and they do impact it. Sports is a big deal, and fitness and all these folks, they usually are prone to having some problem. I've been in martial arts, so I know about it. And sometimes you deal with some of it, and it's difficult, right? And the other thing is, there is no limitations to when you think that you got it, like nothing's going to happen to you. I don't think that's the case, because anyone at any given time can, start a problem in their body, and that pain stays with them.
Absolutely.
So that being said, let's break down the concept. How does it work?
Right.
What does it affect, and the different types that may be out there, and then scientifically, if you can, I'm sure you can, and then we can break down like the solutions, the method,
sure.
How we can treat it all.
Sure. So first off, let's just hit the idea. You mentioned pain management several times.
Yes.
People should be afraid of the concept pain management. You have to really wrap your head around this idea. Pain is not representative of chronic illness. If you have cirrhosis of the liver, that is a tissue that is deteriorating, and you have to deal with that. If you have stenosis of the mitral valve, that valve is slowly, progressively shrinking, and you have to deal with that. Chronic pain simply represents the fact that a tissue is in distress, eliciting the pain you're experiencing, but you haven't identified that tissue, which is why it continues to elicit the pain. So when someone reaches the point of saying, I'm willing to accept some form of pain management, what they're saying is they're willing to use some technique to manage the fact that the pain continues to be elicited because of the fact you haven't identified the tissue. So if you suppress your awareness of pain, how does that help you identify the tissue in distress and resolve that distress? You understand that it's eliciting pain because it's not functioning properly. And it's trying to say to you, help me. I need help. I'm not functioning properly. I need help to make me function properly. And if you never seek that tissue and identify it, you think it's just going to magically get better on its own? What if it's your heart? What if the pain that you're having is coming from your heart? You think the answer is pain management? Just don't experience the pain. Guess what? You're dead. You had a heart attack. So let's make sure we understand pain management is in existence for one reason, and that is because the medical establishment's mechanism of diagnosing the tissue in distress fails so extensively that they have come to the point of having to say, we kind of give up. We really can't identify that tissue. So at best, all we could do is try to help you manage your pain. So let's be very clear. Pain management wasn't an answer. It was a cop-out. It was a default position because the medical establishment cannot. If I could identify the tissue today and resolve the distress of it, your pain would be gone today. Why would I need pain management? So let's be very clear. Pain management is a default position to a failed system.
I really love this interaction here because you're right. I mean, pain is an alert. Your body is telling you there is a problem. And by the way, same thing as fever. You get fever, that means something's wrong. So it's like, wake up, hello, do something, right?
Correct.
And you're right. Now the pain is there. You live with it. Some is manageable, some is not. But you're right. The cause of the pain is really what needs to be treated.
Right.
And so. But you're right that the reason we refer to the word pain management is because sometimes, to your point, is like, well, I mean, especially in some situation with cancer and, maybe late stage, disease type of things. And, people are really not gonna, there's no resolution to the problem.
Correct. That's right.
We just kind of ease them out through that process of pain management.
That's right.
And you see that in a lot of end of life type of situations and
correct
hospice care and even in some other I guess
people with MS. There's no question that there's systemic disease that warrants it. Mm-hmm. But what about neck pain, back pain, shoulder pain, knee pain, hip pain, ankle pain? What the hell is that? Where's that considered a chronic disease? Chronic illness.
Well, coming from you as a PT, I mean, specialist, that. I mean, those are the things and muscles and stuff. You're right. Those are not, terminal. They're just there. And we cause the pain for them somehow by tearing a muscle, by,
correct,
doing something wrong. And we all do. We lift something wrong. We sit wrong. We sleep wrong. Now we have, I started like always referring to phones, but really you see this movement here.
Right.
The neck is always in pain.
Right.
So now let's talk about, I love the way you define that and clear that, because I think now everybody's clear. If you listen to the show, the difference. Pain management is almost like a patch to get you. It's like, a little drug to just numb the pain for a minute. And same thing like and it's funny because when we take like Tylenol, Advil, any of those NSAIDs, right? They kind of like suppress that pain. Basically, all they do when they send a message, there's nothing but the pain. The problem didn't get away. It's still there. It's just that your brain says, okay, I don't have a communication. I'm good.
Correct. The pain signal is still being elicited. Everyone has to understand The pain receptor, wherever that tissue is in distress, is still firing pain signals to the brain. Non-steroidal anti-inflammatories act as sedatives. So it makes the aspect of the brain that experiences pain and kind of almost freezes it or softens it. So you don't really experience the signal, but the signal's still going off and that tissue still is in distress. Absolutely.
Wow. Well, thank you. I mean, I think that was a great point, for at least the first, establishment here that we clear, that fact with everyone. Now, let's talk about the, solution.
Yeah.
How do we do this?
Yeah. So first, let's get to this. So you hit on something, and I guess let me just at this point.
Go for it.
Everybody always says, oh, if I do something wrong, if I hold my phone like this, if I sit too long, if I stand too long, let's end the premise that any particular activity, any particular task, any particular posture is bad. There's no such thing. Now, people oftentimes say, oh, I have carpal tunnel syndrome, or I have tennis elbow because I have an overuse syndrome. An overuse syndrome. Let's be very clear. Typing, playing tennis, sitting at your computer, is there a set force requirement to do that? Gravity's pushing down on you, and you have to push against gravity. That's what your muscles are doing. So if you do computer, every time you do computer, it's the same force requirement. Every time you play tennis, it's the same force requirement. Every time you sit in a chair, it's the same force requirement. The force requirement isn't changing. What's changing is the amount of strength you have available to push against the force requirement to allow you to do the activity without pain. So let's all end the premise that activity is bad because it creates pain, that there's overuse. It's all nonsense. What you want to describe it as is under strength. You can't sit because you haven't strengthened the appropriate muscles to allow you to sit. You can't hold your phone because you haven't strengthened the appropriate muscles to do it. You can't watch TV or be on your computer or stand or twist or bend because you haven't strengthened the muscles to do it. So the difference between those two premises, and I'm going to show you, you play tennis and you have pain at your shoulder and you go to the doctor and you say, Doc, I have pain when I play tennis. You know what he's going to tell you? Don't play tennis. But you see, what he neglects to understand is that you just worked 50 years of your life so that you could retire and play tennis 7 days a week. And when he says that, it's like putting a bullet in your head. Is that fair? You think that's right? You think everyone should? That's an acceptable mindset? That's bullshit. That's crap. It's not that he can't play tennis. It's that he's not conditioned to play tennis. So if he comes to me and says that to me, I say, listen, my friend, I'm going to do an evaluation. I'm going to establish which muscles are weak. We're going to strengthen the appropriate muscles. And probably in 4 to 6 weeks with aggressive strength training, you're going to be playing tennis as much as you want to play tennis. And if you want to play more tennis, we strengthen you even more. And if you want to climb Mount Everest, I strengthen you for that. So the mindset of the population has become to think that anything that hurts me, I should stop doing. It's just the opposite. You do everything you want to do, just condition yourself. And that is what makes my mindset completely different. You're not going to hear anyone saying this. Everybody's going to tell you, oh, you have back pain when you sit too long. Oh, get an ergonomic desk. Oh, get a lumbar chair. Oh, get 3 pillows. Oh, get a brace for your neck. Oh, get a brace. It's all nonsense. There is a force requirement for the activity, and there is a force output of your muscles required to do the activity. If the force output of the muscles is greater than the force requirement, you do anything you want. So I don't care how old you are. I don't care what your lifestyle's like. You only have to know what you want to do and understand which muscles do it, strengthen the appropriate muscles, and you have the life you choose. That's very different from anything you're going to hear anywhere else.
And it is. And I'm almost sure that folks that are watching right now or listening, they'll be like, Damn. That's
Makes
really,
sense. Makes sense.
Listen, well, the concept of kiss, keep it simple, stupid, right?
Yeah.
It's really the same here. I mean, it's as simple as that, but you're right. I mean, sometimes we don't look at it that way. And depending on who you seek the assistance from, you get different angles, right? It depends on the expertise of that person.
Sure. But you have to, what I want, another thing people understand, chronic pain is a sociological phenomenon. Let's go through some other aspects of this, and this will help people understand this. Chronic pain never existed in the history of mankind prior to the late 1980s, early 1990s. Nobody understands this. It never existed. There was never chronic pain. Go back to the Greeks, the Romans. Chronic pain has never been identified in medical history. Okay? So prior to that, who were the people who typically talked about pain? It was retired people. It was older people, and they retired. And they used to call it rheumatism. My rheumatism's acting up. My rheumatism's acting up, right? So the premise was that once they retired, they did less activity. And as a result of that, they were more susceptible to straining when they tried to do activity. So that's why it was that group. Now we get to the late 1980s, early 1990s. What happens? That's correct. The computer was 99.9% industrial based. By the late 1980s, it's now completely the opposite. It is almost exclusively personal. We have not just the use of the computer, but the occupations associated. What's the largest occupation in the world today? IT. Not even close, right? So now you have a job where people are on the computer 10 to 12 hours a day trying to create code and all the other stuff. Everything associated with the computer. We have the laptop. We have the cell phone. I could give you like really obvious kinds of things. So when you wanted to get money out of the bank, I don't know if you're old enough, but I'm surely old enough. I would walk into the bank and there was a person called the teller. And I would hand them a withdrawal slip and they would count money and they would hand it back to me or take a deposit. Well, that person had to sit there and do active stuff, manual stuff. How is it done now? Through an ATM, right?
Well, through actually apps, you don't even have to do anything. You get apps now when you just cash cards. You just tap your card.
Right, exactly. Even that. Look how they're even making something like that, right? So how about this? How about the fact if I wanted to change the television channel, I used to have to get up, walk over to the TV, and turn the dial. Now, not only do they have remotes, but they have voice-activated remotes. So I could change the channel just by my voice. I don't even have to use my thumb anymore. And so what you see is that all people, not just the elderly, all ages, becoming more and more sedentary, making them more and more susceptible to having pain because their muscles are straining. So now I've treated people who are 20 years old who tell me it feels like I have a bobblehead. I cannot support the weight of my head. A college student says my neck muscles have become so weak, I can't support the weight of my head. 20 years old. Right? So chronic pain becomes this epidemic initially because of the fact that the age population suffering from pain expands massively from the 60s and up all the way down to now the 20s. So that creates the population. Part of technology was the development of the MRI. The MRI is set to find the cause of pain. By the way, I guarantee you, great trivia question. Who knows what was the reason the MRI was created? It wasn't for that. That was not its intention. Its intention was to identify tumors in the brain. The MRI was developed to identify tumors in the brain. That's what it's designed for. Somehow, and I can show you now, try to go back and find the answer. Somehow, magically, it's now shifted to have a secondary purpose as identifying the cause of pain. And there were no studies done. It simply happened. Well, it starts to identify these structural variations wherever the pain is. Herniated disc, right? Well, what if those aren't the cause? What if they are muscular cords? Well, I just said muscular cords don't show up. So you now are treating the wrong tissue, the tissue that's not in distress. You're just treating an arbitrary tissue that happened to be identified. So what happens to the tissue in distress? It remains in distress and remains eliciting pain. So you have the false acute cause that remains the false acute cause over time. That's what leads to chronic pain. So acute pain is the misdiagnosis coming from the MRI saying that it's a structural variation when it's muscular. Acute pain is what I say, chronic pain is misdiagnosis. It's the fact that it continues on and it's never changed. So as a result of that, that muscular cause remains. If you understand that premise, then it should then begin to understand why is there a global chronic pain epidemic of people from the 20s to the 90s. I just described the entire concept to you.
Well, doctor, I think there's more than that. I think that's getting even younger these days, because even kids now, there's no activity. When we were kids, you play outside.
There you go. Right.
Now they're just stuck in a room in front, again, in the computer, in the same position, everything, and they're just gaining weight. And
there's the answer to childhood obesity. Everyone keeps talking about McDonald's. It's not the McDonald's. It's the fact that kids don't move. And you know how you know that's true? Because the NFL started that promotion of that start 60 or play 60 promotion that they did, which is, I find this insane. They're promoting to children to run around for 60 minutes a day. When I was a kid and you got home from school, you didn't stop running until your mother called you in for dinner. And then you went out after dinner. You ran for 8 hours a day, 6-8 hours a day, and on the weekend constantly. It's so bad that they're just trying to promote for a kid to run 60 minutes a day. It's insanity.
Well, because unfortunately, that's where we are today. Kids don't leave the home. They don't want to leave the home. They don't go out. They don't even. I can say my own experience. I have a teenage kid, and he doesn't want to go anywhere. Right. We leave. He's with grandma. He doesn't want to go anywhere. He's playing. That's it. One thing that you mentioned, and it's important, I think, to highlight, and I want to just reemphasize this. You're right about the 80s and 70s, well, the 80s and 90s and stuff, and the age groups, because in the past, the jobs were more physical. Mm-hmm. Historically, people worked; they were active. You don't sit behind something. You actually work physically, manually somewhere. And so your body is always muscular. It's you're building mass. You're building, your body's, strength and core strength. Now if you grew up and you're like a techie or whatever, you don't go to gym. There's no muscle. There is a muscle, but it's not, toned up. It's not. And by the way, your story actually relates to that, because when you were younger, and by the way, I love the way your energy is about the physics of it and the force. Oh yeah. Yeah. You've done all that study, in advance, to all this, and you learned about the physics concepts and stuff. But that's real, gravity, forces.
Oh, absolutely.
Stuff is the real thing. So that's almost, a big deal to highlight today, because people don't see it that way. And if you're working out every day, you tend to have better core muscle and core strength and everything. You can do more in physical activities. You might have temporary pain just because the muscle is, recuperating, but it goes away. You're like, wow. And actually that's true. When you work out less, you tend to have more pain. You walk, everything hurts. You work out more, you feel like strength, and you're like, really like in shape. And that's what we say. You're in shape.
Yeah, absolutely.
That's a real, fact. I've experienced it. When I don't work out, everything hurts. When I do work out, things are better.
Right. And so one of the points you were making, which is critical to understand, is that muscles not used lose their force capacity and their mass. The idea of if you don't use it, you lose it. So when people had physical jobs up to the late 1980s, they were using their muscles, and so it was sustaining the strength. Even people who work out, if you then don't apply that strength in activity, you will lose muscle. If you want to see it again, I can show you a theoretical premise. What is the greatest fear of every astronaut that goes to the International Space Station? These are guys who are elite. These guys are in elite shape. Everyone who goes up there, the greatest fear, the thing they're most fearful about, is the amount of muscle mass they lose. Why? What don't you have at the International Space Station? Gravity.
It's true. And a lot of them, they come down and they have to do some exercise and rebuild. They come up, much lighter than when they go up.
Yeah, they develop squat machines and treadmills. I've seen it where they have straps attached to them, and they're trying, but without gravity, you don't have a force that you have to push against. So it becomes very hard to create weight, because the weights would just float. right? Because it's not against gravity's not pushing it down to the core of the earth. And so these are critical things for people to understand. If you don't want to have pain, generalized, let alone chronic, and you reckon, and so here's another key point. So people often say, so, you know, oh, you're saying that this is muscular, it's not structural. How do you know that? They found a herniated disc. Okay, well, think of this. If it was a structural problem, wouldn't you assume that your pain should be somewhat consistent and somewhat throughout all the time that you're existing? Because it's structural. The torn disc or the broken disc or whatever they're talking about, or the arthritis, it exists. So you would assume that your pain should be somewhat constant, and somewhat balanced in the intensity. It should basically stay about the same. Well, how come most people say that their pain begins or is initiated or exacerbated when they do activity? And then when they rest, the pain reduces. Well, I don't understand. Are you saying that when I'm walking and I have knee pain, I have arthritis, but as soon as I sit down and I don't have pain, the arthritis disappeared? It disappeared? Is that what you're saying? I don't know what that means. Oh, I have pain if I stand and I have stenosis, but when I sit down, I unstenose. I don't have the narrowing of the spine in it. Wow. You see, these are the types of things that when you're evaluating an individual and you ask them questions about their symptoms, you can then start to make conclusions. If you're going to the medical system, let's face it, no one can deny this. Your diagnosis is blankly decided by the MRI finding. Period. End of story. Nobody asks you about your symptoms. No one says, where's your pain? No one says what brings your pain on and makes it worse. And yet, every bit of that is critical to understand what the tissue is that's eliciting the symptom. Because if it's muscle, you're going to assume that if you do things that require muscle, it's going to cause pain. And when you rush your muscles, it's not going to cause pain. And you'll see. You listen to your audience and you'll find out almost every one of them will be able to attribute their pain, the initiation or the exacerbation of it, by doing activity. And then when they rest, it diminishes. That is a red flag. The cause is muscular.
Well, it shouldn't. I mean, ultimately, if you have a problem, the problem is there. It's not going anywhere, and
right.
That's really the bottom line to it. And so it's a contradiction to think that it's gone just because you sat down and it just disappeared. If your disc is twisted, unless you fix it or do surgery, it's not going to be fixed. So
right. But what we're always, everyone has to stop and understand the premise that the reason, and this is where this goes all the way, by the way, this is what Hippocrates said. Hippocrates, the father of medicine, created the words diagnosis and symptoms. He created this. He's the one who I'm just following what's been around for 1,000 years. You have to understand when you're experiencing that pain is coming from a very specific tissue. Let me put it this way. If you have ankle pain, do you think you're having a heart attack? No. But if you have pain at your chest and your left arm, you think you're having a heart attack? You're damn right you do, because that is the symptom that is associated with dysfunction of the heart, right? The tissue in distress is the heart. It creates that symptom. Your entire side of your body goes dead. Do you think you have an ankle sprain? You think you strained your muscle? You think you have a kidney stone? No, you think you're having a stroke. Mm-hmm. Why? Because that's the symptom that's associated with the stress of the brain. So you already have people kind of going into the direction of saying, wow, there's a connection. A particular tissue creates a particular symptom. And that had been around in the medical system until the advent of the MRI. That is a organizational change. The medical establishment went away from trying to connect the cause and the symptoms to simply whatever structural variations identified, that's what we're going to believe.
But doctor, so someone can, ask the question, but why? What's special about the MRI? Why was the MRI the key solution and the default?
That's the great question. That's the question that needs to be asked. That's the question that has, let's put this in perspective. 130 million Americans, 1 out of every 3, 1 billion people worldwide, 1 out of every 7 people suffer from chronic pain. Globally, every person in every country I've ever talked to, their diagnosis has been derived by the MRI. So the problem is that you're just a person in pain. So you just understand that you're this individual and you want to get out of pain. You don't understand that you're part of a systemic disease that's called the medical establishment and the use of the MRI. If people hear things, that's why I'm doing these podcasts. If people suddenly recognize that they're not one, but 1 of 1 billion people worldwide, maybe they'll say, maybe we all have to get together and ask the question, why? Why would 1 out of every 7 people be suffering from chronic pain when the same exact mechanism to identify the diagnosis, the cause, has been used? It hasn't varied. You can't say, oh, well, maybe it's that everybody's not using the same system, and so we have one that's really working and the rest of it. It's the same system. Everybody globally gets diagnosed by the MRI.
Well, so Doc, there's a thing. I'm in the insurance world, and I know one of the services we don't like is MRI because it costs a lot of money.
Right.
And so there may be an answer to it. I mean, it's as simple as that. It makes money. it's
that right now. I'll show you. You've now hit on the ultimate concept. So, would anyone acknowledge that the medical system over the last 40 years has been very successful in addressing pain? Is anyone in their psychotic mind ever going to say that? Clearly not. They have failed miserably. Do you understand the number of people who have killed themselves? The suicide rate has skyrocketed and everyone wonders why. It's because the number of people who are suffering with pain at such a high level have decided they can't live another day on this earth like that. They kill themselves. I have treated hundreds of people who came to me who literally said, standing right in front of my face, I am putting a bullet in my head tomorrow if you don't end this pain. I cannot live another day like this. I can't even get out of bed, let alone function, and I don't want to be here anymore. So suicide rates are up. Depression rates are up. The opioid epidemic. Where do you think that came from? You think that was a bunch of 18-year-old kids who were trying to find an alternative form of heroin? That's crazy. If that was true, when would opioids have been created? The 1960s, when heroin was used at its highest by the teenagers, right? No, you needed a much bigger demand. You needed something bigger. All those people being misdiagnosed and mistreated, now you have a population that warrants these companies to develop these opioids, right? The opioid epidemic is a direct result of the chronic pain epidemic. Irrefutable. It came right after it. Right?
It is still it's a big deal, and
it still is, yeah. And so is the marijuana issue.
Well,
right?
Yeah,
same thing.
And by the way, some people can say the CBD and marijuana right now is the ultimate, solution for the opioid. Just to compensate a little bit. It's less, I guess, aggressive, and it's
right.
more natural. And that's still a debate, and even federal government, for example, in the U.S., have not approved, the use of marijuana as a medicinal piece, in their laws and regulations. So that's already pending, and only states have determined that. And again, it does treat a little bit of the pain, but again, it camouflages the pain. I'd say.
That's just masking. That's exactly.
Right. So, but that's the key. But now there's other people, and by the way, thank you for sharing some of the statistics, because just listening to them, I mean, suicide rate is high across everything.
Scary.
And you're right. When pain is at its top and high, you can't handle it sometimes. It's just like you want to stop that pain, and that's why people numb themselves with things. But you're right. Some people can go just like the extreme way and say, I'm done. And that is sad, and it shouldn't happen. And hopefully we'll bring messages to people over and over that your life is valuable. We want you to live a happy life and a healthier life and joyful life. And there are ways, and some people seek holistic stuff and spiritual stuff and different meditation, but there are medical opportunities. In your case, you have your own method. So let's break that method down. Like,
sure.
How do you? Yeah, I mean, I know you've referred a little bit to the way you diagnose, the way you survey people, but let's break down your process and your uniqueness, your signature.
Yeah. So let's say someone's having lower back pain
Mm.
and they find out about me and they're going to do a Zoom session with me. So the first thing we want to do is try to understand what the tissue is creating that. So the very first question I'm going to ask them is stand up and point to where your pain is. Now, they might have pain very centralized to the spine, or they might have it a little off to the side. Well, if you kind of get a chance to look at this, you'll see there's muscles that attach to all 5 lumbar spine, and then you have muscles that sit off. This is your lower back muscles. This is the psoas muscle. So there are specific muscles. Now, so they'll probably tell me, well, I have an MRI and I have an L4 nerve root impingement, right? What you need to understand about these nerve roots that come out of the spine, every one of them innervates a certain area of skin. They're called dermatomes. The L4-5 nerve root innervates the inner shin. It innervates the area of skin in the inner shin. So if you actually had a nerve root impingement at L4-5 create a symptom, you got to tell me I'm having altered sensation at my inner shin. So is it possible that you're having an L4-5 nerve root impingement, but it's not the most extreme level? There are impingements from 1% to 99%. So what if it's impinging, but it's not enough to elicit a symptom? Can you have it and not create a symptom? The answer is clearly yes. Studies have shown, I mean, in terms of herniated discs, in 1994, a study showed that more than 70% of the population who have no back pain have bulging or herniated discs, 70%. The biggest one is over the age of 60, of the people who have no back pain, 93% are found to have degenerative disc disease. So what you want to start to kind of wrap your head around when you're having to find out about these structural variations is that they're really associated with wear and tear and the aging process. So the identification of it at the time you're having pain doesn't mean it's the cause of your pain. It was there before you had your pain, it'll be there after. So that's the first part I have to try to explain away whatever the structural components are. But now I'm going to say, okay, let me see you from the side. And I might find that instead of having a very subtle arch in the lower back, they have an excessive arch. Well, what would create an excessive arch? Would a herniated disc create an excessive arch? Would stenosis? No, it has nothing to do with that. What would create an excessive arch is shortening of that muscle. If that muscle, that psoas muscle, which is attached to that lumbar spine, pulled excessively on your lower back, it will actually pull the spine into the stomach area and create an excessive arch. So I just established that you have centralized lower back pain and you have an excessive arch. Do those two symptoms go together? Should they be considered? Or should I just ignore the fact that you have an excessive arch? No. Keep remembering your body is trying to present a representation of what tissue's in distress. So all symptoms are available to you. You have to be able to read the symptoms. So that's a symptom. Now I say, so what brings on your pain? And you say, well, I sit fine, but when I go to stand up, I can't stand up. I have to push through my thighs. And eventually, once I stand up, the pain is terrible. But once I stand up over time, it starts to go away. Would stenosis cause that? Would a herniated? No. What would cause that is that muscle is shortened when you sit. And then when you go to stand, you're asking it to elongate suddenly, and it's not prepared to. So it strains and pulls excessively on its attachment to the lower back muscle, to the lower back vertebrae. So that's another symptom. Then I say, okay, let me see you bend down and run your hands down your thighs as far as you can go. And I see how far you can go, and it's very limited. And more importantly, for your natural spine to work properly, you start with a mild arch. As you bend forward, it should actually reverse, and you should be able to hunch your lower back. Well, that person is very short, and they're still in an arch position at the end point. Again, what would cause that? Oh, those lower back muscles, that psoas muscle being shortened, it's not allowing the back to reverse to a hunch. Is that a symptom? Yes. So I just gave you 4 symptoms that I identified through my evaluation: pain centralized in the spine, a severe arching, a mechanism of injury that can cause the pain, sitting for a while, then trying to stand up and having difficulty, limited range of motion through bending. What does all of that information give you? A diagnosis. What's the narrative? You are having centralized lower back pain because you have shortened psoas muscles because of the fact that you've done so much in front of you, and as a result, Your psoas is strong, but the muscle that opposes it in the back, called the gluteus maximus, is weak. And as a result of that, it's allowed the muscle to shorten enough to actually go into spasm and pull excessively on its attachment to the vertebrae. To resolve your problem, I am going to strengthen the hamstrings, the posterior thigh muscles, and the gluteus maximus muscle, the butt muscle, which will both create an opposing force to lengthen the psoas muscle, which will correct your posture, will correct your flexibility, will allow you to stand up without pain, and will allow you to have no pain in your back. That's what somebody wants.
That's what everybody would want.
Right. Right.
I mean, literally anyone with pain. I mean, first of all, if people are listening right now and watching, and when they listen and watching, they would know that I've been there. I've felt something, now I can see it. I can hear it. I can feel it. And I think there is a solution. And again,
Yes.
Listen, you're bringing that to science. So there's no way anyone can debate about it, because again, you're right. There may be herniated disc and other things, and those have their own ways of dealing with them. But the pain piece of it is what we're treating here, we're discussing, and that is your muscle strength. And you're right. Again, I know for a fact, this is my personal experience. When you really exercise and you work everything correctly, you tend to be stronger. You feel less pain. It's not, you really, there's no pain. The minute you stop, things ache.
Yeah.
And the longer you don't do activities, the more pain you do tend to have. And
Right.
This is not with someone with a disease net. Now, of course, people can still question this. Well, I do have pain because of, to your point, ulcers and maybe some liver and other, internal organs, right? Now that's different, right?
Right. But think about what you just said. Okay. Someone's having pain from an ulcer. Would that pain vary if they sit or stand?
Nope.
It's going to be continuous.
That's right.
Right. So you just described one of the key indicators as to whether something's structural, systemic, or muscular. You just described it. If someone's having a kidney stone, trust me, they're going to have that. I don't give a shit if they lay on their side. I don't care if they stand up. I don't care if they take a hot shower. I don't care if they exercise. That's going to be there. That's a red flag for a systemic deficit that needs to be addressed immediately.
Doc, you just hit me. I mean, with the kidney stone, I've been there. I know how it feels. There is no position that can ease it up. You're flying. You're like literally on a frying pan. You're just like moving. I got morphine at the hospital and still didn't do anything. That's how.
Yeah, I've heard it's like the worst pain that ever existed.
There's no description to it. It's just pain. That it's like all over. You just cannot.
Yeah.
You bend down. You do this. But you're right. That's consistent. It's got nothing, and exactly it's something else. But you're right. When it comes to bones and stuff and structure, it's pretty simple. You're almost. I mean, again, I think we've answered some of the I guess the myths here. We busted the myths here.
So let's go to another one. Let's say that you have a compression fracture of your. Okay, let me explain another concept when it comes to how I need people to really understand why you want to really look at symptoms versus what is said on an X-ray or an MRI. Let's take this one. Now we're saying that your pain is 2 to 3 inches off your spine, okay? It's 2 to 3 inches off your spine. And you get an X-ray or MRI. Let's say you're in your 80s. And they say, oh, we found a compression fracture of L5. You need to get surgery. So I want somebody to explain to me, where would you expect pain to be of a fracture in a vertebrae? Would you expect the pain to be at the vertebrae or 3 inches to the side of the vertebrae? Where would you expect that pain to be if you have a fracture of a vertebrae, a bone? Don't you think the pain would be where the fracture site is?
I can say yes, because I had a fracture and I know. Okay. I felt exactly where it was.
Right. So you would expect, based on the diagnosis given by the X-ray or MRI, compression fracture, that you should have pain at the vertebrae, but your pain is 3 inches to the side. That's a red flag. You can't get surgery for that. How do you know that compression fracture isn't degenerative? That it's actually been festering for 20 years. And the body is basically taking care of it. It's there, but it's not creating any trust. It's not creating any impedance of function because it's not eliciting a pain, right? That if the fracture was so severe that it was impeding the vertebrae's ability to support you, trust me, your body's going to elicit pain. But it could be degenerative, and it could have been sitting there for 20 years, but you just strained your lower back muscle. So that's what led you to get the MRI, and you just found the compression fracture for the first time. And because it's found for the first time, at the time you're having pain, it is asserted to be the cause of your pain. That is called correlative theory. And this is the home run ball. If people don't understand this, then they're never going to understand why this should never be used. They're using correlative theory. It's called junk science. It is the equivalent of saying, if I open my front door when the sun rises, I can say opening my front door causes the sun to rise. That is correlative theory. Now I'll show you how it works. So they're saying the compression fracture is causing the pain because it was found for the first time at the time. So let me ask you this. Would the MRI find that you have two elbows? I'm doing an MRI and I check you. Do you have two elbows at the time you're having your lower back pain? Yes, you have two elbows. Okay, so why can't I say two elbows is the cause of your pain? It's the exact same theoretical basis. It's delusional.
Because it doesn't tell you when that happened. It just shows you that it's there, which
that's correct. It's no different than saying you're 5 foot, you've got blonde hair, you've got brown eyes. It's identifying a structure. And what you really want to understand is that the medical establishment, what they attempted to do was to create fear inside fear. If you notice, just so you know, stenosis means narrowing. The word stenosis means narrowing of the space. How come they never say to somebody, you just have some narrowing between your vertebrae? Why do they say stenosis? They say stenosis because they want to scare the person, because it sounds very scary. I just did a Zoom session with a guy today, and I forgot where his pain is, but it wasn't even near his vertebrae. And he was told, oh, you have spondylolisthesis. Grade 1 spondylolisthesis. That's just a shifting of the vertebrae front to back, which can happen to anybody. They tried to scare him into wanting surgeries. Like, he knew me. He knew I wasn't going to buy that. So he's like, okay, thank you. I don't even think that's the cause of it. But that's the attempt, right? So they're trying to incite fear. And because of that, they're trying to get the person to create an emotional connection to this. And they're trying to say, oh, since it was found, and I'm using this big word, and I'm showing you the scary picture that you can't understand, I want you to believe this requires an intervention without question. You need to have something done to this. I found it. I'm showing you the picture. I'm using a scary word. You need to have this fixed. So they're trying to equate structural variations like cancer. They're trying to equate it to cancer. If found, it needs to be addressed. Structural variations are like wrinkles on the face. Nobody is being asked to get skin grafts every time they get a wrinkle. Why? Because the general population is smart enough to understand that although there's a deformation of my skin, the integrity of the skin is still intact. What is the purpose of skin? To prevent antigens from entering the body. So even at the wrinkle, the integrity of the skin is still intact. Therefore, its functionality exists even with the deformation of the appearance of it. That is arthritis, herniated disc, stenosis, pinched nerves. It's all the same. They're wrinkles internally. If you begin to understand that, you won't have the fear. You won't be willing to succumb to what they're trying to do to people. And then you'll be more open to saying, okay, if it's not that, what is it? Oh, that's right. I heard that guy say that he could figure out what it is by looking at my symptoms. Maybe we should actually address my symptoms. Oh, that's right. Who was that who created that? Oh, that's right. That guy Hippocrates, the father of medicine.
Well, Doc, this is amazing. But you know, it's as I'm listening to you, it's almost scary to realize some of the facts that you're describing here. Because one, I mean, imagine how many people could have been misdiagnosed in this case, and potentially undergone different surgeries or procedures unnecessarily. And that's a big issue. And we're not even discussing the cost that it might have had, because somebody's got to pay for these procedures. So,
Yeah.
so the implication here is like, humongous, and there is more to this. This is beyond just identifying that discussion today. I mean, because like it opens up a kind of worms here, like, like a Pandora's box.
Yeah, sure. So to be very clear, I'm telling you, I think 95 to 98% of people are misdiagnosed. I think 95 to 90%, 98% of all surgeries are unnecessary. It's almost all.
Listen,
almost all.
I do not disagree with you. And I've worked again with the insurance and the healthcare, and so I have some good friends, and a lot of the good ones will tell you, you do not want to go in surgery. If you don't have to, you don't, and you should avoid at all means, because there's risk at surgery.
Right.
Besides the financial, it's just the health. And then
Right.
to your point, misdiagnosis means surgery, and there's adverse reactions to these things. Anesthesia, different things.
Sure.
Sometimes, it's funny because I did have a show a couple months ago about a case of someone that was misdiagnosed for almost 3 years under a different treatment, only to find out none of that stuff was real. It's amazing. So I mean, this stuff that we're sharing here today, it's not, this is not sci-fi. This is real. This is truth. People have to be awakened, to be aware. This is not, a theory here, like, one of those conspiracies. It's really real. It's facts. You got to do the research, do your homework, find out for yourselves. There are, things that you might not know because you just follow the system.
Right. Let's be very clear. For people to say there's this one guy, he's obviously a little nutso, he's making this crap up, that there's no way that the entire global medical establishment can be wrong. Let me give you an exact example. George Washington, the father of the American country, was killed by his doctors. This is an irrefutable, completely well-accepted fact. He went out. He went to check out his acres. He comes back after horse riding. He ends up with pneumonia. At the time, the standard procedure for infection was to bleed the individual. You used a razor-like device. You caused them to bleed. They thought that by bleeding the person, the infection would be taken out. They bled him at the neck. He caused an inflammatory response, and over the next 24 to 48 hours, he suffocated to death. Those tools are in the Smithsonian Institute. It is irrefutable that George Washington was killed by his doctors. At the time, the most up-to-date, medically, technologically advanced concept was to bleed people, and they killed the guy. So don't tell me that medical people don't make mistakes. I'm giving you the theoretical, clinical, and scientific evidence. What I am saying, I take on all challengers. Anyone wants to take me on and have a death match as to whether the MRI is real or fake, bring it. I'll take anybody on.
Well, that's pretty powerful. But also, you're convinced, you have your passion, you know your stuff, and you speak based on experience. So, I mean, I would not.
28 years, man. 28 years I've been doing this.
I will not challenge you. And again, when you're confident in your expertise, I mean, I hear you. And I know that fact because in my expertise, I know I will throw the same thing in my stuff, right? If you had to bring it on. But I do want to just make a statement. I mean, ultimately, doctors, in the medical world, and people make mistakes, period.
Sure.
And there's I don't know of any doctor that will tell you, like, you're guaranteed you're going to have the best outcome is going to be resolved. Nobody's going to do that.
Right.
There's also fear from practice. A lot of people are afraid of that. And that's why we have those laws, right?
Right.
So, and again, I would not blanket everybody because I know there are doctors that are trying to do good and things like that. But you're right. In this particular arena that we're discussing, or this particular topic specifically about the body and the pain and the use of MRI, you're right. MRI is imaging. That's what it is. You're taking images of a body and you can show something that you had or you just did, to yourself. But either way, it's not going to tell you when it happened.
Correct.
You tell them I just had an accident. Well, you got something. So maybe the accident or something that was before the accident just got activated.
Right.
And again, that's all. So that's really what MRIs do.
Right. But all I would say is to anybody is, do you agree that there is a connection between the tissue in distress and the symptoms being experienced? Does everyone agree that whatever you're experiencing is coming from the tissue and stress? You have to say yes, because you know the pain at the chest and the left arm is coming from your heart when you have a heart attack. All the numbness is coming from your brain. You have to agree the connection is there. The tissue in distress solicits specific symptoms. So the best way to understand what tissue it is to interpret the symptoms. If that's not part of your diagnostic process, how do you accept the diagnosis? How can you accept that when I just gave you multiple examples where an MRI finding, even if it was found at the time of your symptoms, doesn't match the symptoms that you're having? What that tissue would create in symptoms isn't what you're creating, isn't what you're experiencing. At that point, you have to say, it does sound like there's something not right about the MRI as a diagnostic model. So why, if I mean, you just have to understand how, you just said it, how dangerous it is to get a surgery and end up with a negative outcome and know before you even had the surgery it was going to be a negative outcome. You talk about how pain, you don't understand how over 28 years, how emotionally invested I got in this. You get people who come to you and say, I'm going to put a bullet in your head. You are sober. You are standing at attention. You are scared, knowing that that person's life is suddenly in your hands, and you better figure out what the hell it's going to take to make that person better. And I've had this happen to me hundreds of times, and it is what has driven me to this. Nobody in their right mind is going to come out one day and say, I think the entire medical global establishment is wrong and I'm right. You have to be insane to do that, unless you've been asked to do that, unless your purpose in life was to do this by a higher power, and you were given all the tools to show that what you're saying. This isn't arbitrary. This isn't an opinion. I will go fact by fact. I will go person by person, and I will be able to show you every single time. Now, there are 1.5% to 2% of cases that are structural, and I'll be able to know that through your symptoms, and I will suggest you get surgery. But the other 98.5% of cases, it's muscular, and all the presentation of the body is showing you that it's irrefutable.
So, doctor, I wanted to ask, I mean, I'm looking at the picture, the thighs and the muscles, but I mean, another common element that we hear about pain is sciatica, for example.
Yes.
Yeah. So that's a
big one. Yeah. And, yes. Good.
No, right. Just hold that thought. So that one. And the other part is the concept here of, well, actually, I lost that. So I'll come back to that one. Let's talk about sciatica.
Yeah, let me go through the 4 mechanisms by which muscle can create pain, and it'll probably answer all your questions. Okay. So I say muscle is 98% of the cases. People say, well, my pain is in my knee, or I have sciatica. I feel like it's neurological. Okay, so here's the way it works. So you have the classic example of a muscle straining and eliciting pain. That happens because other muscles that work in conjunction with that muscle have strained first, causing that muscle to overwork. So muscles strain and elicit pain because other muscles they work with have strained first, causing that muscle to compensate. Ultimately, the point to understand is that the cause of your pain in 99.999% of cases is not where your pain is being experienced. It is somewhere else. So that's the first one. Number 2, let's take pain at your kneecap. Very common, pain at the kneecap. Everyone's going to tell you got arthritis, things like that. That's not what it comes down to. The kneecap runs through a groove at the end of the thigh bone, and it is controlled by the muscle on the top of the thigh called the quadricep muscle. It's connected. The quadricep connects to the kneecap via the quad tendon. So if there is an excessive shortening of the quad, perhaps, well, that can cause an excessive upward force on the kneecap, so the kneecap becomes compressed in the joint. And as a result, as you bend and straighten your knee, it's being compressed. That can cause pain. So you have a muscular cause causing joint-located pain, right? So pain in the joint doesn't mean it's from the structure of the joint. It can be that the surfaces of the joint are becoming misaligned because of muscles that attach. That's how you get joint-related pain. Then another thing is people don't know muscles can refer pain. I kind of mentioned it to you because where's that pain at the chest and the left arm coming from? The heart. What's the heart? It's a muscle. So you have the person who lays on their shoulder when they sleep at night, and they end up with numbness in their hand when they wake up, and they're going to be told, get an MRI of your neck. No. The rotator cuff muscle is being overstretched when you lay like that, and it's weakened, and your shoulder gets drawn forward, so it becomes irritated and refers symptoms to the hand. How do you know that's true? Well, as soon as you stand up, the symptom goes away. So I don't understand. If it was a herniated disc at the neck, you just made the herniated disc go away when you stood up. I mean, insanity, right? You can see that. So muscles refer symptoms. Yeah. Finally, muscles constrain and impinge on nerves, and the nerve can then elicit symptoms. That's sciatica. So there's a muscle right here called the gluteus medius. It's a muscle that helps you provide balance and stability. When that strains, a muscle that sits right next to it that runs through the gluteal area called the piriformis muscle can strain as well. That muscle, when straining, thickens and impinges on the sciatic nerve. So you have a muscular cause creating a neurological symptom. So I don't care if anyone works on the nerve. Until you resolve the weakness of the muscles are not going to stop straining and impinging on the nerves. You have to resolve the muscular cause to stop the neurological symptom. Those are the four mechanisms that muscle creates pain.
Wow. Listen, I mean, I'm just like, annoyed because I'm listening to all these, you're breaking it down. And as you speak, and I think everybody who's watching and listening, they'll be like, they can visualize this whole thing and see the correlation between these things, right?
Yes, absolutely.
Actually, what I was missing earlier was when you mentioned about symptoms and diagnosis, and you gave the example of the heart or the stroke. There are people that can be always like skeptical and say, well, those are like the clear ones. We all know about those because we hear about them. But I'm sure there's other things that can give you a similar thing. It's diagnosis and symptoms, and you get a diagnosis based on that.
Well, also all your organs will elicit specific symptoms. So if let's say that you have the flu, right? You end up having, you'll have upper back pain, but you'll also have difficulty breathing, right? So you get a group of symptoms that are associated with pneumonia, let's say, or the flu or something like that, right? Everything. Okay, why do you sneeze? Why do you sneeze? A sneeze is it's an antigen, enters the nose, and interacts with the mucosal lining in the nose, and the mucosal lining identifies it as an antigen and says, I need to rid the body of it, so it tells you to sneeze. So the symptom is the itch in your nose. The sneeze is the response to the symptom. The body, you have to understand, you aren't left in this world to just exist and pray that you're going to know when something's not working. The body has evolutionarily been designed to put in these feedback systems so that you are, if you're conscious of yourself, if you're thinking about yourself, you can become aware of when there's the stress of specific symptoms or specific tissues, and specific symptoms represent specific tissues.
Well, as simple as that. Your stomach is, hurting, you're hungry, you got to eat.
There you go. Same thing. It's true.
As funny as it sounds, but I mean, you're right. I mean, we have a reaction. Your bladder is full, you got to go. I mean, there's a symptom, right. You got to go.
Right. That's exactly right. Right. So that's not an accident that you went to the bathroom, right? The mechanoreceptors in the wall of the bladder have sensed the distension, and it's now signaling to your brain. You need to act upon it, right? So the distension, the sense of full, is the symptom. It's the way the body works. So all I'm saying is that when it comes to pain, it's no different. But people think pain is being this just innocuous. It's always the same. It's not always the same. You have to know exactly where it begins and where it ends. There's a very fine nuance to pain, and you really need to interpret it. And what you have to understand, this is why it gets a little hard for people to understand, whether you're a neurosurgeon or a neurologist, whether you're an orthopedist, whether you're a rheumatologist, whether you're a chiropractor, you are not educated in the understanding of how to differentiate tissues. You are only taught a tissue, right? The rheumatologist is only educated to know what arthritis is. The orthopedist only knows the structure of the joint. The neurologist only knows nerve, right? So they only know specific things. So if the tissue in distress is outside that realm, how do they identify it? They're not educated or trained to. So they have to just put you into something they know, which is why it leads to misdiagnosis.
Well, I mean, someone can argue that these doctors, they did have a regular standard medical background before they get specialized, and they also cooperate with other doctors. But again, you're right. If I only see my view and I just interpret it from my level of understanding, there's a good chance that that's where I'm going to be limited to it. And you're right. Unless
you have to be.
I mean, it's amazing. I mean, you're thinking sometimes in surgery, there's multiple doctors in different disciplines, and they can all, kind of have a discussion about the case, and maybe there's a diagnosis, and then there's a treatment course that's subscribed. I mean, that's prescribed. But so I mean, again, there's a lot more to it. But you're right. I mean, the concept that you're sharing is that simply people are experts in what they know, but there's something beyond their realm, and therefore that's where the issue is. We can't all be surgeons, right?
Right, but the point about chronic pain, which makes it so unique, has gastrointestinal disease existed through the history of mankind? Yes. Sure. Has heart disease? Yes. Has bladder disease? Yes. How about chronic pain? No. It has not existed until the late 1980s and 1990s. Clearly, something distinct has occurred. And the reason for it is because there's now another tissue which has never been a factor in the medical system, has become the primary cause, the tissue in distress, eliciting pain. Where has that been entered into the curriculums of every other medical specialty? Where has that come? Where's that? Go look at the curriculum from 1973 for an orthopedic surgeon and look at it today. Tell me it's different. It's not. It's the same.
Doctor, a lot. Well, you're right. I mean, certainly there's a lot of shift in a lot of things the way we live, but also I think the way we eat, the way we sleep.
Sure, that's a factor. Sure.
Yeah, I mean, like
sure.
Back in the days, I mean, now you have all these kind of beds and stuff, and your body is so cushioned. It's not actually, getting any force, pushing against it as much as it used to. I mean, people used to have hard beds and whatever. I mean, we can go back in centuries, and they didn't sleep in plush.
Sure.
Sure. And so there's all of that, right? And
sure.
It's amazing. But so I wanted to just go back to the method. We talked about your diagnosis, how you process it, and you've given all the examples and how you do it, and you did a great job with that. So is there anything else in the process that your method, has in addition?
Yeah.
So now you did all this. What's next step?
So now that we established which muscles are responsible for the symptoms, now we have to know how to strengthen them. Mm-hmm. And what makes my understanding of how to strength train comes from this understanding that I developed from physics. So every muscle moves one joint in one direction. So you have to set up the resistance exercise for that muscle in a way that the resistance band is going to be moved in with the joint in the direction that muscle moves it. So for instance, if we were going to do knee extension, which is to strengthen the quad, we have to attach the band to something behind us. It has to be put around our ankle. We have to make sure that the rest of my body is fully stable, because all I'm trying to do is straighten my knee. That's what the quad does. And then I'm going to apply that resistance and make sure that that's the only muscle that's working, because we've identified only 3 or 4 muscles that are responsible for the pain. If you try to do this and compensate, you're never isolating the specific muscles. Therefore, they never get stronger. Therefore, you're never able to accomplish your activities without pain. So we have to make sure that the person does these exercises in a very exacting way. And you have to know how to choose the right resistance, whether you're using resistance bands or machines or dumbbells, whatever. And so all of this comes into play. And then you have to know how to use the right level of resistance. And that has to do with something called the perceived exertion scale. And that's a part of this whole thing. And then there's also understanding about how long to rest in between every set, how many sets to do, how many repetitions, how often to do this. Yass method, you never do your exercise more than 3 days a week. This idea of working every day is completely false when it comes to making muscles strong. Muscles get stronger when you cause them to adapt to greater and greater resistances. As you're doing that, you're creating micro tears in the muscle, and that next 24 to 48 hours after the bout of exercise, the muscle has to heal and make more muscle, so you cannot strengthen it while it's in its healing phase. So all of these are integrated, and the sessions that I do are videotaped. That's another important thing to understand. So they're videotaped. So what happens is at the end of that, the next day, they're going to get the copy of the video. And they're going to watch the video several times so that they understand the theoretical basis why they're having the pain. And then when they're going to do the actual exercise the next successive days, they're going to watch themselves on the video, do it with all the cues I'm giving, and then they're going to hit play, and then they're actually going to do the sets of exercise, watching themselves do the exercises on the video. And that guarantees you a higher level of accuracy in doing it. And then what typically happens is you do that for 4 weeks, 3 times a week, and then at the end of that, we do a follow-up session. And I'm going to see how you're progressing. Are your symptoms reducing? Are you improving your function? I'm going to ask you to do the exercise as much without me involved to make sure you're doing it correctly, seeing you're utilizing the resistance, and we just progress this. And usually over 2 to 3 months, the person is pain-free and fully functional. And what's important to understand is I've empowered them. They don't need anybody else. No more medical people, no more medications. They just sustain this exercise routine. And as long as they sustain it, they're fully functional and pain-free.
Wow. Well, so there's something you just mentioned, and it's pretty common when, and I know you worked out at the gym. You did some, early on when you were buffing up.
Oh yeah.
And it's a big deal when you have to do the different muscles in different days so you can rest the ones that you work. That's pretty common in fitness and bodybuilding.
Right.
But so the other thing that you mentioned, then I wanted just to get the attention to is you're working with people all over, and sometimes you want resistance and stuff. Now, if someone that may not have equipment, how easy for those people to do the exercise?
So usually people can always have access to resistance bands. You can get them on Amazon. If you're in, I don't know how it is in Europe, but in the United States, you just go to your local Target or Walmart and you can get a pack of 3 resistance bands. That's the beauty of the method, is that you don't need dumbbells. You don't need equipment. As long as you have a resistance band, I can strengthen any particular muscle I want. And I've been doing that for years. That's all you need. A chair and a resistance band. That's the total amount of the equipment to use the Yass method.
And if there is no resistance band, is there anything like a substitution that you can use that may be easily accessible?
Well, if someone's available, there's always the opportunity for someone to apply manual therapy, and I could explain how that person tries to resist you. You'll always have to go through the one joint going in one direction to isolate that particular muscle. But then, depending on what's available, you establish the best mechanism to develop the resistance for it. And you have to have the resistance. Anyone who tells you doing calisthenics is going to make you stronger, absolutely not. It's impossible. Muscle only adapts to get stronger and make more muscle mass by causing it to adapt to greater and greater resistances. That's a critical component.
That's why when you bodybuild, you have to put extra plates in there. How much you bench press?
Just keep going.
That's right.
That you just keep getting stronger.
Well, I mean, again, weight training is a key for that.
Sure.
And again, gravity resistance and all this stuff is revolving around the same concept. Well, thank you. So now the other part is there anything else in the method? I think we've covered the whole.
Yeah, I think that's it. Yeah, I think they understand it. Yeah.
So then the last part, I mean, financial access to it. I mean, is it how, I mean, I know this is private, it's not through insurance, or is it covered?
Right. So that's a big thing about, I've treated people at the end stage when they've had all the multiple surgeries and they've tried all the nonsensical, they've tried stem cell and plasma therapy and all the other psychotic stuff, which is actually, you have to pay privately. And so I've always wanted to make this economically reasonable for as many people as possible. So I said, what's the best way? What is it that they need from me? Well, you need a diagnosis, you need an evaluation. Diagnosis, you have to know which muscles are working, you have to know how to work them, and then how to use the right resistance. So certainly that first session is critical. But once I did that, and then I give them the session, the video, my opinion is, well, the next 4 weeks, they kind of can do that on their own, because they're using the video to make sure they're doing it accurately. And then in 4 weeks, I'm going to do a follow-up. So basically, you see me every 13th session that you're exercising, and the sessions cost $200. But if you divide 200 into 13 sessions, it's like $18 a session.
Well, I mean, when you
$18 every time you're doing your exercise.
You can have a meal these days costs more than that.
Right. And so just so I want people to understand, I thought very hard about this. I want this accessible to as many people as possible, and I wanted to make it in a way where my time is valuable to me in certain aspects, but in certain ways, I don't think it's as valuable. And when you're doing the exercises, as long as you have a general understanding of how to do it, you don't really need my understanding, my education, my background. And that's why I feel like the best way to do this is I see you, you do it for the next 11 times, then I see you again, you do it for the next. And so it's, in my mind, this has become the most economical way of doing this for people.
Well, doctor, I mean, I think you got a great point there, because and I know about copays and co-insurance and stuff, because that's what we do.
Yeah.
I mean, those things can be costly for any of the procedures you
Sure.
mentioned. I mean, some of these procedures, the copays are more than your cost for 2 sessions. So,
Yeah.
so I think
Well,
that kind of ends that.
Even if you go for physical therapy, it's going to be a $50 copay 3 times a week. That's $150. That's $600 a week.
There you go.
And
So,
you're no closer to getting better. You don't have a proper diagnosis. You're not being shown what to do. Here, you spend $200 in a month, and within 3 months, typically, you're going to be pain-free, fully functional, and you have the full understanding. You are empowered. You know what you have to do. It's not like you're blindly saying, "Oh, I'm just going to have to go to somebody and do what they tell me." That's not what I'm looking for. I'm looking to empower people.
well, it's
They
also,
get control.
it's also home. You don't have to go far. There's
Absolutely.
transportation,
Right.
tolls, whatever. I mean, there's more to it. I mean, so considerably, I don't, the cost is really affordable. And
Yeah.
And the other part is, at the end of the day, if you're really miserable and pain and you're like, suicidal or just getting to a point where you can't stand yourself or you got to undergo some serious procedures, your health is everything. I always say health is wealth. And so investing in your health is the key to everything. You can't be happy if you don't invest.
Absolutely.
In your health. So
Yeah.
it's the same thing. Like, people, you mentioned tennis. It costs money to buy gear. You like
That's
golf,
right.
It costs money
That's
to
right.
buy. So,
That's right.
But you can't do any of this unless you have your body functional. So I think on the flip side, we have to be aware that, and thank you for sharing. I mean, not everybody is willing to share the cost of their services.
Yeah.
And, thank you for that, because it kind of puts things in perspective, because, oh, I can get this. I can even save towards this and get started. I mean,
Yeah.
So thank you for that.
And
Now-
in terms of scheduling, by the way, you just go on the website, livewithoutpains.com. You schedule the sessions. I don't schedule them. There's a Calendly thing on there. So you pick the day and time that works best for you. So that's another comfort aspect of this. So you're getting to pick the day and time that works the best for you. So
Listen, I love it. I mean, you make it as easy, as accessible as you can get.
trying.
Well, listen, that's great. I mean, not only it's telemedicine, it's up to date. It's definitely bringing, a different perspective on how to manage. Well, not even manage, to treat.
Yeah.
Because manage is one thing, but treating is the ultimate goal. And so that's impressive. And thank you. I mean, you have a strong opinion about your method, and I think it does work. I mean, I haven't used it personally, but what you've provided us with today is concrete things. It's not just, theories, it's practical.
Absolutely.
And we can all relate to it, and we can all understand it just by listening and watching. So we're coming out to the end of the show. We went over the hour, but
I know.
It was all good. Like I said, I always say this, I can't stop when we are really dynamic and everything is good, because we want the full experience here and people can get the whole picture.
Yeah.
So wow, thank you, Doctor. I mean, it was
My pleasure.
Any last words of advice that you want to share, and we can end the show about that.
Yeah, I just want people to understand that it's obviously a very, very bad place to find yourself when you're in chronic pain and you keep trying all these different methods and nothing's working. And what you're going to be tried to be convinced of is that you've gotten the right diagnosis, you just haven't gotten the right treatment. That at some point has to wear thin. At some point, you got to say, it may be possible I got the wrong diagnosis. That's why all the treatments haven't worked. And don't give up. Don't give up on the idea that you can have your pain ended. My premise has always been in life, for every question, there is an answer. Every question has an answer. You just got to find the right person who can answer it. And hopefully I presented that today, and there could be some trust, and you'll give this a chance. And all I want is for any person who's in pain to have the ability to be out of pain. And if I could be a factor in that, I believe that's what I was chosen to do, and it is my honor. And I believe it is a gift that I've been given and a gift that I like to give to others. So please take that into consideration.
Well, no, thank you. And I think that's important because at the end of the day, our platform is to share resources that can help people. And you just hit on a note there where you listen, you try different things. There's always another way. Try it. I mean, that what's the least that's going to happen is that you at least tried it, and you can either thumbs up or thumbs down. But at the end of the day, you would have, tried something different.
Absolutely.
If all the others didn't work, well,
keep going.
Yeah, keep going. And when you get to that, and to each his own, right? I mean, I know it works, but like there are people that found, holistic approaches and meditation, other things. And, there is your system, your method, and it's solid. It's effective, and it's been in place. So again, same message here, same mission is that we want people to be better and have resources. And yes, it's a legacy that we want to keep, and give to people and just access. So information is free.
Absolutely.
And yes, the description of the show, in the show description, you will have the website and the link so people can actually search and certainly. Now, is there a consultation prior to the session, or they just have to?
No, the first session is the consultation and treatment.
Okay, good. So that's
the intent is that by the end of that first session, you feel substantially better. I will prove that the system is correct and that I have properly diagnosed you. At the end of your first session, you will have a substantial reduction in symptom. I won't stop until that happens. I hate to say it, but it's true.
Well, so I have to say, not everybody gives a warranty and a guarantee, and you almost are standing behind your seal here, and that's actually important. I think in terms of just confidence, we all can feel that you're confident and you're definitely sure about the results, and I think that's because not a lot of people can tell you, oh, we're gonna get you better. We're gonna try.
This is the real deal, man. This is the real deal. I put my stamp on this. It's real.
That's right. Well, listen, we will take your word for it. We will take your results. We will take your results for it because I know they're documented. And with that, I want to thank you for a great time and a great show. And certainly, folks, thank you for being with us, listening, watching, and hope you will, if you have a need for the services, seek the services and see your health better. That's all I have to say. That being said, thank you for watching. Hurricane H here. We'll talk at the next show, next guest, next topic. Bye-bye.